Our next session is session 12, and under this session, we will be discussing tonsillitis and peritonsillar abscess. The session deals with the management of patients with peritonsillar abscess and tonsillitis, and students are encouraged to identify patients with such conditions and share experiences and outcomes on Sakai. Students are also expected to apply the nursing process in the management of these patients. And we move on to our first topic, and that is tonsillitis. Tonsils are masses of lymphatic tissue located on either side of the oropharynx. So once again, you are being referred to anatomy and physiology to revise tonsils. And we have three main types. We have adenoids, we have the palatine tonsils, and then the lingual tonsils. So that's a diagram showing the tonsils. That is the tonsils. Tonsillitis is inflammation of the tonsils as a result of bacterial infection or maybe secondary to a viral infection of the upper respiratory tract. Example, we have rhinitis and sinusitis. All these may lead to tonsillitis. It may be acute or chronic. So in the diagram, we have normal tonsils and then inflamed tonsils. Acute tonsillitis normally affects the palatine and lingual tonsils, while the chronic one is an untreated acute tonsillitis which develops into chronic. It is less common, that is the chronic one, and may be mistaken for disorders such as allergy, asthma, and sinusitis. Tonsillitis is mainly a disease of childhood, but it may also be seen in adults. And it's one of the most common childhood health problems affecting children between 5 to 15 years, but rare in under 2s or children below 2 years. 2 years. Streptococci throat infection is the common form of tonsillitis. So the cause is primarily infection, and it has both viral and bacterial causes. So the following are some of the bacteria that cause tonsillitis. Please refer to the slide. We have the beta hemolytic streptococcus and then other bacteria. The viruses have been listed on the slide: measles, we have coronavirus, and others, to mention a few. The mode of transmission, the infection or bacterial and viral infection that cause tonsillitis are contagious and spread when an infected person talks, coughs, or sneezes. So it's acquired through droplet infection. The manifestations include visibly red and swollen tonsils, blisters or painful ulcerated areas. The person may have sore throat or there's sore throat, fever, pain that is referred to the ear, and then on inspection, the tonsils are seen to be enlarged with exudates and pus, the sleep apnea, and bad breath or halitosis. That is a severely infected tonsils in the picture. Other manifestations include difficulty in swallowing or pain on swallowing. We also have enlarged and tender lymph nodes in the neck and jaw, runny or stuffy nose, sneezing, coughing, noisy respiration. There may be chills, malaise, tiredness, vomiting, difficulty in opening the mouth, loss of appetite, breathing through the mouth. And the individual may also have dehydration of the skin and mucous membrane. It's diagnosed through physical examination. Palpation of the neck and jaw may reveal enlarged swollen lymph nodes. Diagnosis is also through history, complete or full blood count, and then throat swab or culture and sensitivity. The following are some of the medical treatments given. Viral tonsillitis is self-limiting and needs no antibiotics and usually resolve within 2 weeks, but bacterial tonsillitis may respond to antibiotics such as amoxicillin clavucillin or clavulanic amoxicillin. Erythromycin can be given as well as azithromycin and clindamycin. Uncomplicated tonsillitis also resolve within 7 to 10 days. Analgesic and anti-inflammatory medications may also be administered. As a surgical treatment, tonsillectomy may be done, and this is indicated when there is recurrent tonsillitis where medical treatment is not successful, or in severe hypertrophy of the tonsils, in peritonsillar abscess, obstructive sleep apnea, and then tonsillar malignancy, and repeated attack of purulent otitis media. That is a surgical removal of the tonsils. Preoperative preparation. Ask patients to stop taking medication containing aspirin, as said in the previous slides, for surgeries of the ear, nose, and then the eye. And if it's a child, tell the parent to be with the child at least before surgery. Maintain adequate hydration should also be maintained. They encourage good oral hygiene. Clotting profile of patient is checked. Vital signs is monitored, and any infection is treated before surgery. Pre-op teaching include limiting talking after surgery, reporting frequent urges or the urge to swallow, and then patient is told or parents are told that stool may be tarry for a few days due to initial blood swallowed. Teach patients saline gargles as well, and then patients should be told that the voice may be abnormal, like dark voice, which is normal and may last for 3 to 4 weeks or earlier. But patient is also told that there may be bad odor from the mouth for 7 to 10 days during the healing process, and throat and ear pain are common. He or she should avoid sneezing or clearing the throat, and in case of normal, any medication such as asthmatic inhaler, if patient is on any such medication or any of such medication, it should be taken along to the theater. Post-operatively, patient is positioned, oral airway should be removed, sputum mag is provided, and in case of large amounts of bleeding, the surgeon is notified. Report and observe and report for restlessness and bleeding at the site, and then assist patients to wash mouth with saline solution. Vitals are monitored, then throat is observed for signs of swallowing, and cold compresses or application are applied to the neck to constrict vessels. Ice cubes when the ice has melted. Cold drinks may be given, or ice cubes should be changed when the ice that's applied as cold compresses are melted, and cold drinks which are not acidic may also be given. Stress that client reports any frequent urges swallowing, which signifies bleeding. Instruct client to avoid vigorous toothbrushing or gargling to avoid bleeding. Client is also told to avoid spicy, hot, acidic, or dry, like toast and chips till healing is complete. So liquid or semi-liquid meals are encouraged, or client is educated to take such meals for 2 weeks as can tolerate. Discharge, client is educated to avoid travel on airplane or far away from a healthy facility 2 weeks following surgery. And pain, severe pain, should also be reported, and should be told that pain may be referred to the ear and therefore should be expected. However, if it's very severe, it should be reported. Complications of acute tonsillitis include peritonsillar abscess, chronic tonsillitis, rheumatic fever may occur. Then the patient may also have otitis media, mastoiditis, sinusitis, and sepsis. Our second topic is peritonsillar abscess. and this is also known as quinsy. It develops above the tonsil in the tissue of the anterior pillar and the soft palate, and the peritonsillar abscess is a collection of purulent exudates between the tonsillar capsule and the surrounding tissues, including the soft palate. It is secondary to tonsillar infection, and it is seen as a painful condition and can be life-threatening. It's also seen as a complication of acute tonsillitis. The infection spread from the tonsils to the surrounding peritonsillar tissue, forming the abscess. So that is how a peritonsillar abscess looks like. It may be caused by group A beta hemolytic streptococcus, and others can be anaerobic organisms, and it has an incidence of 1 in 10,000. It's the most common deep space infection of the head and neck that presents to the emergency department. It presents as difficulty in swallowing or dysphagia, thickening of the voice, or the sound of the voice is muffled. There's a muffled sound. The severe sore throat radiating to the ear. There may be drooling because patient has difficulty swallowing, swelling of the soft palate, ophthalgia, and there may also be odynophagia. Diagnosis and management. Aspiration of the abscess is done for culture and sensitivity, and medical management include warm saline gargle, ice collar application, and analgesics are given for pain, and then antibiotics are given as prescribed, and patient is educated on the importance of completing these antibiotics, and hospitalization may be necessary if airway is compromised. Incision and drainage is done with antibiotic therapy as a surgical management. Tonsillectomy can be performed to avoid the recurrence, and aspiration with a needle may be done. And preoperatively, again, I'm referring you to pre- and post-op management of patients with tonsillitis. So please go back to the second topic under this session. Inflamed tonsils are very painful and may impair the feeding and communication of the patient. Nurses are to observe for bleeding through observation of frequent swallowing, and the right antibiotics should be given to patients with peritonsillar abscess at the right time. The following are your references or reading list for further information regarding the topic.